From diagnosis to recovery, the journey through macular hole repair. Macular hole surgeries rank among the most common vitreoretinal procedures performed today. With continuous advancements in imaging and surgical equipment, the outcomes of macular hole surgery are improving steadily. Along with the good clinical evaluation, optical coherence tomography is indispensable for evaluation of macular holes. OCT helps us stage the macular hole, measure various indices, and prognosticate surgical outcomes. In this video, we take you through the intricacies of the steps to perform a successful surgery to achieve macular hole closure. Ways to tackle PVD induction. Successful induction of posterior vitreous detachment or PVD is crucial for macular hole surgery. The PVD must be induced beyond the equator up to the ora serrata. While a pre-existing PVD is occasionally present, PVD induction is typically necessary in most macular hole surgeries. Using the macular lens of the wide-angle viewing system provides a magnified view, facilitating PVD induction from the edge of the optic nerve head. Triamcinolone acetonide is particularly effective for this purpose, as its crystals adhere to the vitreous, making it visible and easier to identify. Additionally, BBG dye can be used to stain the vitreous, with the blue color aiding its identification. Staining the internal limiting membrane. Brilliant blue-green or BBG is the preferred dye for staining the internal limiting membrane. After vitrectomy, BBG can be injected directly into the fluid-filled vitreous cavity to stain the ILM. For a more intense stain, the dye can be made heavier, allowing it to settle on the retinal surface. Another effective technique is to perform a fluid-air exchange and apply the dye under air, which also enhances the stain. Decoding the techniques of ILM peeling. Initiating the peel of the internal limiting membrane or ILM can be approached in several ways. The pinch and peel technique, where a superficial pinch raises the ILM flap, is the simplest method. Alternatively, tools like the Tano's diamond-dusted scraper or Fenner's loop can lift the ILM flap. Once raised, the ILM should be peeled circumferentially, grasping near its base. To prevent detachment, it's crucial to re-grasp near the base after each peeling segment. A peel from arcade to arcade is the most preferred. Inverted ILM flap. For large macular holes, typically with the apical diameter of more than 500 microns, an inverted ILM flap can be used. The ILM is peeled, leaving it attached to the edge of the macular hole. It is then trimmed to appropriate size. A small bubble of PFCl is injected on the posterior pole to prevent flap dislodgement, and then the flap is carefully placed in the macular hole. Following a sufficient peel, a thorough fluid-air exchange is done. Ensuring a good drying of the retinal surface is necessary for macular hole closure. A non-expansile gas is injected for internal tamponade, followed by post-operative face-down positioning. By meticulously addressing each step, surgeons can achieve successful macular hole closure, helping restore visual function for their patient.